Yeah. Hello, everybody. Welcome. This is Professor David Jones. As he says, the grandfather, great-grandfather of PBC, and I'm the great-great-grandmother. And we've worked together. I think it's 30 years almost we've been working
Indeed,
together.
it is.
And yeah, I think we're celebrating next year. And we're here to answer your questions. Now, I'm just going to say a couple of things at the very beginning about housekeeping. First of all, we can't, under any circumstances, compromise any of our medical advisory, and Professor David Jones is the chairman of our medical advisory, and he understands perfectly what I'm saying, but we cannot compromise them or yourselves by answering personal questions about your own personal PBC, because we'd be asking him to comment on a small part of a story when he would need the whole file. So we can't do that. So, but we'll answer general questions. And the other thing I'm going to say, David, you weren't aware I was going to say this, but we've had a number of inquiries about Ocaliva. Yeah. We will not be answering questions about Ocaliva, not because we don't want to. At the moment, our CEO, Robert Mitchell-Thain, when he's back, he will be working with Professor David Jones, as I say, the chairman of our medical advisory, and our medical team, and we will putting out statements on our website. Mm-hmm. So that's the best we do, because these are individual comments, different countries, different things. So it will be done properly when the team are together and for statements to be made. And it's not that we don't care, we do, but we will try and answer all your queries when we have all the information. Is that reasonable, David? You're happy with that?
Yeah, I would just say one thing, which I think I can tell you from appropriate conversations in the last 48 hours, is that and I appreciate there are people from around the world on this call, but the status of OCA in the UK is unchanged. Okay. So it remains exactly as it was before, a licensed and approved treatment, and trials of OCA in the UK that have originated in the UK. So that it's a little bit complicated. So the trials that we're doing, for example, Opera and Oaks, remain ongoing. Excellent. And OCA won't be reviewed or looked at by the MHRA, apart from in their annual review of it, which is as part of its licensing, which will happen in January.
Excellent.
So
that's super.
There is concern. I understand that. And, I think,
we'll leave it
as you said, we don't want to go into a lot of detail about this.
Until we actually have
it's kind of not been handled in a very patient-friendly way. But for those people in the UK concerned about it, it remains exactly the treatment it ever was. And I personally, if you use this drug correctly, and that's true of all drugs, have no concerns whatsoever about its safety. And we started 3 people on it yesterday as part of our normal decision making about which second line is the right one for a particular person. So I think it's just worth saying that. We have clarified that with the company and the MHRA this week, just to be able to give people information.
So watch our website, please, people, and we will be making announcements. That is a guarantee. So David, we've got a lot of questions today, so we're going right in there. The first one, a really good question, David. For those of you out there, there's something called rifampicin, which can be quite helpful for the itch. There's a shortage of that, and is there a temporary alternative, David?
Okay. So that was an inevitable. I mean, in a way, when thinking about, people know from these sessions, it's a rich diversity of questions. But boy, did I predict that 2 things would come up today. One is OCA and one is rifampicin.
Yeah.
So to rewind a little bit about rifampicin, and obviously one of the things I'm aware of, and one of the fascinating things about PBC is that some people absolutely never get any itch and have no idea what we're talking about. It's really interesting because the disease is the same in those people, but they just don't get it. So this won't apply to everybody. PBC patients split into thirds, roughly. A third, no idea what you're talking about. A third have problematic itch, and they're the sort of people who might end up getting rifampicin treatment. And a third have itch if you ask, have you got any itch, but actually doesn't need treatment. And that's really important. So just because you've got itch doesn't mean it needs treatment. The question is, do you want it? Is it bad enough for treatment? So about half the people I chat to in the clinic, they're keen to know that they're, keen to understand why they've got the itch, but it's actually not a problem. Okay. So actually we only ever suggest treatment. We ask people, is it bad enough for you to think about treatments? Okay. Or change in treatment. So, there are different theories as to why people get itch, but my personal best guess is that there are differences in individuals about how transporters work in the liver. So your liver transports bile and things actively out into the bile acids and things actively out into the bile. And those vary from person to person. And this is why some people get cholestasis, poor bile flow in pregnancy, because this is part of it. So these differ from person to person, and some will work very effectively and some won't. And we suspect that probably, and these will be independent of PBC, but if you happen to have the sort of poor bile flow of PBC, and you then happen to have a kind of low effectiveness transporter, this is all my theory, then you are prone to getting itch. And then if all that happens, there is likely to be something that you eat, drink, breathe in, whatever in the environment that causes this, right? So, and the reason
I'm on sugar. I'm listening to stories about sugar. So keep your ears to the ground, David.
And the reason I say there's something in the environment, and that's environment in its broadest possible sense, is the real oddity about chili. So chili has the highest incidence of cholestasis of pregnancy in the world. Okay, and people always thought it was genetic because obviously it's kind of the coastal strip beyond the Andes, so quite a homogenous population. So there were certain genes that were thought to be more common that caused cholestasis in pregnancy, and at one point the incidence is about 1 in 100. Okay, and now the incidence is 1 in 1,000, but that's happened in less than a generation. So it can't possibly be any change in the genes. It's got to be something people are eating, drinking, breathing in. So that's why some people get itch. When people have itch, what we do is essentially get the basics of controlling the disease correct, because some people will improve with it. Actually, some people can get worse with it. We need to be aware of all of that. So you get the basics of treating the disease right, and then you look at treatments that you can give, and we start with topical treatment, so creams and things like that, to take the edge off it all for a milder itch. And then if people need a kind of treatment, if you like, we then have a ladder of treatments that we use. So we start with cholestyramine Questran, which many people will know and all of you will love, which is a fairly unpleasant treatment to take, but it's the kind of approved treatment. So we tend to start with that, and then we move on to what you'd call a second line treatment. So we talk about first and second line treatments. Urso is a first line treatment for PBC itself. Then we've got the second line treatments, but we also do the same thing for itch. So cholestyramine is first line, and then we use other drugs.
And can we just say before you go on, because we do have 2 questions about rifampicin and itch. And if you are on cholestyramine, there's sachets, they're packets you make up into a gloopy drink. If you are on those, it's really important you take them away from your other medication, but take a couple of sachets before breakfast and possibly one after. What you do in the morning matters at night when the itch is worse. So can I just interject with that? David, just while we're on the subject. Sorry.
Yes, and in particular with Urso and Ochre, if you take Ochre, because they're bile acids, and this gloop will bind those. And actually, one of the reasons why it doesn't work for itch is that it's just binding Urso, and so you lose the effectiveness of both the itch and both the Urso and the cholestyramine. So that's our first choice treatment, and then we move on to other therapies. Now, for the last 30, 40 years, probably the most effective of those treatments has been rifampicin. And it was a chance observation. Okay, so back in the day, and rifampicin is an old-fashioned antibiotic, which is where the issue arises. And back in the day, people thought that PBC might be an infection, and therefore they gave an antibiotic, and it did nothing for the PBC itself, but it took the itch away. And so much of what we do kind of comes from these observations. So people made that observation, and then they actually did very good quality clinical trials. So it's really been well researched. This is undoubtedly a very effective treatment.
So what about the shortage, David?
Yes. So we've used that drug because it works, right? And there are issues with it, but it's not a perfect treatment. There are good treatments, and now, as Collette says, there is a shortage. Now this is also something that Robert is getting to grips with as to exactly what's going on. What I can tell you is that we're told it's a worldwide shortage, and it isn't, because as Collette mentioned, we have a worldwide medical advisory board, and I've spoken to the international members of that, and their countries are not seeing it. So there's no shortage in Australia, Canada, USA, Italy, France, Germany, right? So there's something about the UK and a shortage for it, but we are where we are. And there are two aspects to this, which this is important. One is there is guidance that has come out from the Department of Health, the NHS England, and we think in also the devolved nations as well, because it was a sort of joint piece of work, saying that we shouldn't prescribe it, or giving the conditions under which you can prescribe it, but those do not appear to have noticed that we're using it in this particular indication. Okay. And obviously, from my perspective, I will always do what is the right thing for the patient in front of me. And if people can't organise drug supply in the NHS, they need to get better drug supply people in the NHS. That's not my problem. It's not the patient's problem. And so I'm happy to write prescriptions. The problem is, for some people, there are doctors won't write prescriptions. And the other one is that if you can't get that actually dispensed, I can write whatever I want. But if the drug doesn't physically involve. And so we saw an issue with this originally, and people were going to smaller independent pharmacies and were still getting the drug. And then now that's become more problematic. So it's now a point where the drug doesn't seem to exist. Okay. But it does in other countries. And as I say, I think there is, today isn't the day to talk about that, but I think that's worthy of some.
We're looking for a solution for these poor people who really are struggling with their itch and can't get rifampicin. What can we offer them, David?
Well, you can offer them and the glib advice we've got is suggest an alternative. But given I've been working for the last 30 years on alternatives, that's easy for a civil servant to say without any knowledge whatsoever. So what we are doing, first up, is considering bezafibrate. So bezafibrate is one of the second-line therapies we use in PBC. And it has also been shown in a trial to be beneficial for itch. Okay. So given the shortages now, we would not look to start somebody on rifampicin until things become simpler. We would start people on bezafibrate. Okay. So that is a perfectly sensible alternative. There are a couple of caveats to that for people who can't take bezafibrate, right? So one of them is if you've got kidney problems. We don't see kidney problems, particularly in PBC, but if you happen to have kidney problems, you've got to be careful with it. And there is the potential to interact with statins. So the easiest thing is don't start people on rifampicin, start them on bezafibrate, right? The problem is if you are established on bezafibrate, and in particular rifampicin, it has been very difficult to get you established, and many of the people that we have on rifampicin can't tolerate bezafibrate, so that creates a problem. There are two alternative routes here. I mean, there's a third one, which I'll say. So the first alternative route is there are new drugs coming along for itch. So elafibranor and seladelpar, which are also second-line therapies, are much more effective for itch. And we have spoken to both of those companies about the extent to which they may be made available for people with problematic itch. So we've got that rabbit running. And there is also a drug called linerixibat, which is the one developed with GSK and Collette knows all about this. She was there at the genesis of this, as I was, and they are also aware of the situation, are looking to find a way to make that available on what we call a compassionate basis, where people are really struggling will be able to get. And this is a completely new drug, so I think that's a very good bet. They are looking at that. It's currently not licensed, but it will be. I mean, we've seen all the trial data, but there is a route to do that. So that is all. Those irons are in the fire, and those companies are very constructive and understand the pressures we're under, the pressures patients are under. So that's one route. Okay, new therapies. The other one is that we've always had some additional therapies we've used in people who can't take rifampicin and bezafibrate, and those are drugs like gabapentin. Anybody who comes to our clinic, very familiar. We use a lot of that. Naltrexone is a drug we used to use a lot of. We increasingly use light therapy with people, so there may be people on the call who've done that. That can be very effective. So we do have a number of sertraline. So there are we do have always had a range of additional treatments. It's a moving target, and it's very difficult to know for an individual. It's to do with the history of what drugs you've had, what other drugs you're on, and all of that. I think maybe we should be, this is something to take offline, Collette, is maybe if rifampicin is not going to be available for 6 months, we should write maybe a piece of guidance that people can download to take to their clinicians about what I'm doing. I mean, we run a specialist itch clinic, so this is a live issue for our people.
Organise that. The other thing I would say, non-medically, because I'm not a medic by any standard, I've seen the nurses in the liver clinics, if from the old days, they have large tubs of Epsom salts, and if you have a bath with Epsom salts before you go to your bed. And I've also heard that washing your hair with Vosine dandruff, it doesn't matter if you don't have dandruff, but Vosine apparently helps the head. I'm going to keep hammering on, David, because we've only answered one. Yeah,
sorry. And just one other thing. So things like there was a vitamin E bath wash was something which a lot of people have commented on. The third thing, so new drugs coming along, you have to leave that with us. We're working on that, okay? And this is for people for whom bezafibrate is not the answer. New drugs that we're working on, and that's in hand. The step ladder of other drugs, which are out there and in the guidelines and things. And the third thing is you can write to your MP, okay? Because this was a political decision. This was not taken by doctors. We weren't consulted. You weren't consulted. This is a political decision.
I didn't know that, David.
Sorry?
I didn't know that.
Yes.
That's appalling.
If this impacts on you as a tax-paying NHS patient, personally, I think it's because the NHS won't pay the market rate for rifampicin, okay? Which is then going to other countries that will, and it's as simple as that. There may be other reasons which I don't want to go into. So I think this is a directive from NHS England and Scotland and Wales. It's not a medically led decision. And this is why I, as a doctor looking after a patient, will not automatically do this, because actually I have an obligation to the patient, not to an NHS England directive. But none of that helps you if you can't get the drug. And those are the other alternatives. So
everybody keep in touch with us, and we'll try and get something written up here. I'm going to hammer on, David.
Yes.
Creatine. Am I saying that right? Creatine. Is it safe to take when you've got osteopenia?
Yes.
Okay. I had.
It helps with muscle. I would be very interested. So it helps with muscle strength. The bodybuilders, people with perfect physique like myself,
absolutely,
So people, athletes and bodybuilders use it. It helps with the muscles. I would be really interested if people feel it helps with fatigue, particularly batteries running down. So anybody who uses it and who feels it helps, do let us know. Because I've not had that conversation. I'd be interested to know.
Okay, next one. I've had a transplant due to me having PBC, but I really get bad hot spells and it gets worse at night. Could this be PBC related? And before you answer that, from a non-medical point of view, I don't know about your hormones or anything else. I always say to MD, with a new symptom, something different, get checked out, tell your hepatologist, but also practically you can buy cool pillows. The menopausal women get them, they're quite good. But David, could it be PBC related?
With a caveat, probably not. it's not a PBC thing. I would look much more towards the immunosuppression. So the calcineurin inhibitors, the kind of cyclosporin and tacrolimus, would be much more likely to be the candidates. The only caveat is that where people get what we call autonomic dysfunction, so their blood pressure drops when they stand up, which is a common feature and is also part of the fatigue complex of PBC. So we did a load of work on that, years ago. Where people's blood pressure drops when they stand up, sometimes then you can get facial flushing as part of that because you get a tachycardia because of adrenaline. So if it's not just flushing and feeling hot, if it's feeling dizzy as well, then it might be worth getting the clinic to check your blood pressures when you're lying and standing. That's the only caveat, but not PBC itself.
So somebody's asking a question, it's not really a question. Is there any benefit or necessity of changing my Sika syndrome diagnosis to Sjogren's regarding the need for added treatment? Sjogren and Sika syndrome, they affect mostly PBC with eyes and mouth. I sometimes speak at the Sjogren Society, and people who have Sjogren's only without PBC, that's a whole different thing. But I don't think it matters whether you've got Sika syndrome or Sjogren syndrome. You treat the symptoms.
I think you've just summed it up perfectly. Actually, the
the
Sjogren syndrome is from the name comes from the era of bearded gentlemen from the 19th century having diseases. There was a Dr. Sjogren, and so it was a pattern of things. And primary Sjogren's is actually quite a horrible condition, which causes the dry eyes and the dry mouth, but you also get really bad joint problems. And we don't really see that. What we see is kind of Sjogren's light, if you like. And the Sika complex. So Sika is dryness of the eyes and the mouth, and Sika is part of Sjogren's syndrome. Most doctors, to be honest, use it interchangeably. So I'm probably guilty of that. And very, very unusual for a PBC patient to need the sort of treatments they need for Sjogren's, which is usually biologicals. We never do that. So for us, it's focus on the actual symptoms, dry eye, dry mouth, and ameliorating those. It never turns into Sjogren's syndrome. So it's very important, if you go and look at the kind of internet, not to look at some of the stuff around Sjogren's, because that's not something we see. It's a milder variant of that. Absolutely. Sjogren's disease and Sjogren's phenomenon and things like that, terminology is weak. I wouldn't chase it. Everyone in PBC knows what they're talking about. And
there are treatments for dry eyes and dry mouth. I would say to you, if you've got dry eyes, make sure your eye drops are oil-based. You can go into a Boots optician, and they have experts that can just talk you through.
A couple of points from that. The first is I couldn't agree with that more. That any eye symptoms, your optician should be the first port of call, or or Boots or somewhere like that. So opticians are really good at this, and they actually have direct referral into hospital eye services. So
not everybody knows that, David. So if you go to your optician and whatever they spot, they can. It's something urgent, like my husband was detached retina. They had him into the eye pavilion straight away.
Exactly, because of detached retina, because of glaucoma and things like that. So they're really good. So don't have to worry about going to get an appointment with your GP. If you're worried about your eyes, you can literally just phone up, go and see Specsavers. Specsavers, other opticians are available. You can go get an appointment tomorrow and go into the system, and they've got all the technology. So that's the first thing to say. But just going back to the Sjogren's thing. Don't worry, we do the antibodies. I mean, we're not silly. So the antibodies that would make it proper Sjogren's, we check those as part of what we do. So when I say we don't see proper Sjogren's, that's because we actually look for it, because on the off chance we'll see it at some point. So don't worry about it. We don't assume that, we actually look for it. And which
is helpful. And that's answered two questions, David, because somebody's asked something.
I'm on a roll today.
You're on a roll. Here's a quick one. Yes, no. Is there any current research on CART cell treatment for PBC non-response? Yes, no.
Not that I'm aware of. We're not involved in any. It's an interesting idea. Am I allowed a slightly longer answer? Quickly. Basically, there are two bits to PBC. There is the immune response, which causes some of the damage to the bile ducts, and then there is the consequences of poor bile flow. And most of the problems we see are down the consequences of poor bile flow, but not the cause of it, if you like. And so all the treatments we give are about the bile flow. So the moment we don't treat the immunological bit, so CAR T cells are a clever way of treating the immunological bit of it. Where people have just looked at treating the immunology, it hasn't really worked. But that's because they've done it without treating the bile duct bit, if you like, which is already there. So a really clever way to look at curing PBC would be to give something like CAR T cells together with a really effective bile acid therapy, and that would deal with both bits of it. But I'm not aware of anybody actually doing that at the moment.
Okay. Thank you. So I've got an inquiry here, which I'm not going to pass over to you, but just to say to the person, they're 70, they've got PBC, AIH, and osteoporosis, etc. And they're asking questions really, which is about their personal health. And I do apologise that Professor Jones, our medical team, can't really answer personal questions of this nature. They can be very, very general, but this is too personal for us to just give you advice that without a complete picture, it could be wrong. So we're not going to go into that.
And can I just comment on the kind of personal side of that? And we do get that. I mean, some of the ways PBC impacts on people.
Yeah.
Most of we find in our clinical service that, there's myself and there's Kath, who's, a very experienced nurse in her 60s, who's been talking to PBC patients for 20 years. Actually, she's easier to talk to about a lot of things than I am. Okay. And we're very aware that people want to come along and talk to her rather than coming to talk to me, and that's just fine. So you're not going to upset anybody, but sometimes a lot of clinics now have really good specialist nurses who are more focused on the kind of personal and holistic aspects. So
these questions about this person's own personal medication.
Yeah, okay.
Which,
I'm just saying, generally
your
speaking,
point is absolutely valid.
If there's kind of stuff you don't want to talk about with somebody like me, male, then go and talk to the specialist nurses. They're really good.
They're fabulous. Yes, I've met Kath. She's fabulous. And give her my regards. Okay.
Oh, well.
When a partial responder to urso has seladelpar added to it, but the biochemistry still shows elevated levels, twice at least as high as ULN, what else can be done to support them?
Sorry, I just missed the beginning. The sound broke up.
When a partial responder to urso has seladelpar added to it, but the biochemistry still shows elevated levels, twice at least as high as that ULN, what else can be done to support them? So
seladelpar is one of the new second line therapies. We don't have it in the UK. We have it on a compassionate basis, so we've treated a very small number of people with it, but it is approved in a number of countries around the world. So and it's one of the drugs you use when people's urso response isn't enough. And one of the things we talk about quite a lot in these sessions is what's enough for an urso response, and that actually depends on you as an individual. Okay, so it depends on how badly affected your liver was before and how old you are. In simple terms, if you're 30, you're going to need 50 years out of your liver, so you need a better level of control than somebody who's 90. That's kind of common sense if you think about it, right? So it's very difficult to say what acceptable is, because that's about the individual and their own risk factors. Generally speaking, so ULN is upper limit of normal. So the reason we don't talk about an absolute number, because different labs use different assays, and so the values can be affected by that. So we use the kind of multiples, the upper limit of normal. So if somebody's got twice the upper limit of normal, that is not a good enough response for what we're looking for. So almost without exception, that person needs better treatment. Okay, you can contextualize it, but that is pretty much in the red zone for everybody. Okay, now the options, basically we have two types of drug. We have a few options around the seladelpar type. So seladelpar, elafibranor, or bezafibrate, fenofibrate are all kind of variations of a theme. And then you've got another class, which is the obeticholic acid, the OCA class, of which there is only one, which is OCA. Okay, so you can go for one of those or a combination, right? in simple terms, so you can use one, you can use the other, you can use a complication, you can use a combination. We tend not to. So is it worth trying one of the other drugs that's like seladelpar? This is a really live issue at the moment, because we've now got multiple drugs, and we've never been in a position before where we've had to think about when do you swap one for another. But we're now having to think about that. So should you try elafibranor as an alternative for that? Well, it's a reasonable thing to do. It works in a slightly different way, and so it might be a reasonable thing to do. The one thing I wouldn't do is replace it with bezafibrate, because bezafibrate is kind of a milder version of these. So it might be worth trying to replace the seladelpar with elafibranor to see if that just works better for you with that slightly different profile. There is no point in adding elafibranor to seladelpar. That's adding two drugs that work in the same way, right? And so there's nothing to be gained from that. I wouldn't swap to obeticholic acid if that's available in your country. We tend to, in our experience, find that swapping one to the other doesn't do it. We tend to go to adding. And so in the UK, if you didn't get the desired result with seladelpar, we would move to obeticholic acid plus one of the other drugs. And that's pretty much where we would go. And that's why we're so keen to keep obeticholic acid, because without that you can't give the combination therapy. So all things being equal, and obviously age and other factors and come into this, I would be looking to get one, better control, and two, to think about doing that by doubling up the therapy. But you're into quite experimental territory. I can tell you where you add bezafibrate, for example, to obeticholic acid. In our experience, people do very, very well, and they tolerate them both very well, and you get really striking response. So the doubling up works pretty well. When I say it's experimental, it's not. It's pretty routine, but it's not in the guidelines yet, because it's in the specialist centres.
Okay, so there's another quick little one here. Dr. Mel spoke about dryness of the bowel being part of Sicca syndrome. How can this be eased, and which doctors should approach? GP, gastroenterologist, specialist hepatologist? Can I just say to this person, I would like to know how much water you're drinking. I spoke to somebody the other day having bowel problems and enormous fatigue, and I asked her how much water she drank in a day. She said she didn't drink any, but she had 2 teacups of tea. So I would be saying to this person, seriously look at your water intake, because you want a good 3 or 4 litres anyway. But in terms of who she would want to discuss it with, I mean, GP, gastro, specialist hepatologist, you discuss it your GP first, wouldn't you? Just, or any of the above.
I mean, yes. I mean, dry, gullet is a sicker thing, because the reason why it doesn't feel dry is because of the saliva, right? And so, I mean, and Collette, I know you've talked about this frequently. The topical treatments for Sicca, dry eyes and dry mouth, the dry eyes treatment, the drops are very good, and as Collette said, absolutely, it's not saline drops, okay? They disappear very quickly. So it's ones that have got cellulose, slightly more oily ones that stay in the eye, and they're very effective. There are artificial saliva preparations. I have to say, the people I talk to don't tend to be a big fan of them. So there are a number of them, but they do taste a bit like chip fat spray, and which is not a great image if you think about it. And so I've never really found one that people rave about. And I think you've tended not to find that, Collette, from people you talk to. So what I say to people is just to have a glass of water always with you and take a sip all the time. And a little tip, sparkling water works better because there's more surface area, because you've got the bubbles, so it makes your mouth feel sort of wetter. Don't drink lots of full sugar Coke. Right? Just get cheap sparkling water. But it does. So people who've got swallowing problems because of narrowings in their esophagus will swear by fizzy water actually is more helpful. So just ease, and remember, there's some of the dry food you eat, a dry beef sandwich, chew it plenty, small bites, and take a sip with each bite, and it will feel much more comfortable. And anybody who's come to our clinic will know that our mantra is 2 liters before lunch. So 2 liters of fluid before lunch. It regulates your blood pressure, helps keep things perfused, and it will address a lot of these things. So people do just get dry.
They actually do. But you know, it affects your skin. You know, it could be aging as well. It's you need your water. Now, I've got a question that this concerns me. Why do you lose so much muscle wastage? You shouldn't be losing muscle wastage unless you're sitting around, not exercising, walking, etc. That's not a PBC thing, David.
No, we don't tend to. Sorry, just 2 seconds. I mean, we lose muscle mass as we get older, right? I mean, so that's a fact of life. But it's not particularly a PBC thing. So what we tend to do is to lose. So when you look at the muscle things, the kind of batteries running down, we did again a lot of research on this a few years ago. What you don't do is lose strength, interestingly. So people don't lose strength, their muscle remains as strong, and they don't lose muscle mass. What they lose is the ability to power that muscle, particularly repeatedly. So people, if we get somebody to do some exercise, the very first time they do it, it will be the same as you would expect for their age and sex, but their ability to keep doing it is where the problem lies. So it's an energy thing, not a strength thing. It's a sustaining thing. So, and obviously how strong you are, how big your muscles are, and how strong they are is dictated by, you know, age and sex. So I wouldn't tend to think of muscle mass as being particularly a feature of PBC. However, there is a caveat again, which is we do see a thing called deconditioning. So if you put a plaster on somebody's leg, okay, because they've broken their leg, then when you take that off, how did you do that?
I fell along Princess Street. It was a dip in the pavement. It's a scaphoid, but it's the same thing. It comes off tomorrow. Way! There'll be muscle wasting in there, and I'll have to work like
exactly. So when Collette takes a cast off, you will see the muscles will have disappeared underneath it, and the reason is you need to move muscles to be able to keep them functioning, so your body recycles them. So you know, it's extraordinary if you've you know got a broken femur and your thigh is immobilized. It's extraordinary what it looks like when you take it off. People who are immobilized in ITU, you know, can come out without their muscles. So if people are really not doing anything at all because of the fatigue, then you could get some muscle wasting. But there are some inflammatory things. There's a thing called myositis, polymyositis, which is another autoimmune condition which you can see in PBC. So it needs a little bit of thought. There's a test called creatinine kinase. Not creatinine, that's a kidney test, but creatinine kinase, which is a first test to look at whether the muscle's healthy or not. So I would go and talk to your GP and then take it from there.
I would also add another wee thing. When I was at 50, I went back on a bike cycling. And when the season started in the spring, I was in agony and I had loads of, you know, really sore legs coming off the bike, need them massaged, and I dreaded every spring. But once the season got going, I'd cycle till October, November, I'd be fine, you know, after a few weeks. However, when I got a dog and I was walking the dog, you know, every day, I was out in the winter. So by the time the spring came, I didn't have any problems getting on my bike. It was continual, having a steady routine of exercising.
And I saw there was a question about osteopenia in the chat. Okay.
It's here.
Yeah, which is actually relevant to this. So why do bones get stronger? Well, they get stronger because they get worked. So if you think a muscle attaches to the bone above and below a joint, okay, so your knee, you know, you've got the muscle above and a muscle below, and that, you know, is and you move your joint by that muscle contracting. Now, we're used to the fact if you go to the gym and you exercise on a machine and do, you know, those lifts, your muscle will get stronger and it will swell because the muscle grows. And that's because of the effect of the exercise on the muscle. So that's Colette's argument that your muscles function because you work them. The same is actually true of the bone. So the pull of the muscle on the bone makes the bone want to grow. And that's why the most important thing for muscle strength is exercise, but the most important thing for bone strength is also exercise, because but you don't see the bone swelling. It's that pull, it's that sort of pull and pull and pull and pull and pull. So actually it's repeat exercises
which will help osteopenia.
Is very helpful. So the answer to osteopenia, so osteopenia is a sort of a low level loss of bone. So the answer to osteopenia is not drugs and tablets. Make sure you eat and drink plenty of dairy, and your vitamin D is all right. So vitamin D as a vitamin is important, and then just exercise. Okay. Exercise, and don't smoke. But nobody on this call smokes, I would imagine.
Do you know, smoking is bad for everybody, but particularly PBC.
It's bad for bones particularly. So don't smoke. That's the other one. And all of that is more to be aware of if you have a family history of osteoporosis. So if mum had it, or an auntie had it, be more aware of it. For men with PBC, there's a much lower risk of getting osteoporosis and osteopenia because you're naturally protected, but the actual additional risk through having PBC is actually higher for the men, but the overall risk is lower because men are naturally protected because of testosterone. There you go.
Okay, great. I'm sure I've got some of that testosterone stuff, you know. Right, there's a big question here from Anne-Marie. How do you explain my disease to my family? If they're not on board, do you think it's just like diabetes? I don't actually know what you mean by it's just like diabetes, but can I just say, Anne-Marie, print some stuff off from our website. We've got a fantastic patient leaflet, and maybe sit them down and explain to them what it is. You know, your body's attacking your liver, your bile ducts, and
I'll just give a quick answer to that, which is how I kind of rationalize it to relatives in the clinic. So the first thing is, this is one of those things. That's the first thing to say. You did not cause it. You could not have prevented it. It is not caused by anything you've eaten, drunk, taken, etc. It is one of those things. Okay. And all diseases are a combination of an inherent risk to do with how your body is built, which is a genetic thing, together with something which made the immune system function in a strange way. I always say it's about it, you know, disease. PBC is a bit like, you know, being 6'6". Okay, if you're 6'6", you bang your head on the door, and it's partly genetic because, you know, you're tall because you have tall parents, and it's partly environmental. There's a door that's lower than 6'6". So what caused you to bang your head on the door? Well, it's a combination of things, but actually there's nothing that you could have done to have prevented it. So it is a random combination of how your immune system's built together with something that you couldn't avoid it that set it off on a path. And none of that is in a way helpful because you can't go back in time, and even if you knew you were at risk of it, you don't know what triggered it, and so you couldn't avoid it. So what you do is look to treat what you have and control it the best you can. The important thing is you can't pass it on to anybody, and we shouldn't blame anybody for any disease ever, but there's absolutely nothing you could have done to have prevented this. And I always say to people, if you're going to be philosophical, you know, if you're going to have a condition, this is actually a better condition to have than many. You know, you could have turned up with lung cancer, and which has already spread, and that's kind of a bad thing. Whereas this, it's diagnosed. The biggest risk in PBC is for it not to be diagnosed. It's diagnosed, it's completely treatable, it's one of those things, and it doesn't present a risk to anybody else. And so I think sometimes there can be a little bit of, you know, the tutting, and everybody knows about the alcohol.
I can't tell you how that you don't know this. I haven't told anybody. I was at the hospital yesterday with a relative who just was diagnosed of inoperable lung cancer, and I was thinking, phew. And I've only got PBC, but I want to say to Amy as well, well, tell them what your PBC means to you, what your symptoms are, what you're struggling with, because they think it's just an autoimmune disease. Well, it is an autoimmune disease, but what it means to you, where you're struggling, what your issues are. It's about you and your PBC. Okay, so that's a conversation I was had. Anne-Marie, I know you've got my number, and feel free to text me and I can give you a call.
On that it's just an autoimmune disease, there's kind of quite a lot packed into that. Every autoimmune disease has two sides to it. It has the immune process, which is why you've got it, and it has the consequences of that immune process. Every autoimmune disease does. So for diabetes, for the type 1 diabetes, which is the younger person's diabetes, the immune process is something you simply don't notice. Okay, it's a very mild inflammation, but it affects the cells that produce insulin. So you wouldn't know it unless, of course, you don't produce insulin, in which case you get diabetes. So in all of these conditions, the immune bit is pretty mild in terms of its impact. It's the consequences of it that cause the problems. So in PBC, we have this quite mild immune response. Its consequences, poor bile flow and all the things that flow from it. Thyroid disease, the immune response is quite mild impact on the thyroid gland, but the consequences all come from high or low production of thyroid hormone. So it is an autoimmune disease, but all autoimmune diseases have two levels of impact: the sort of narrow impact, which is usually quite mild, and then the consequences, which is what impacts on everybody, and it just needs understanding. And over the years, I have spoken to many people, as Collette will have done, and sometimes, I'm sorry to say, understanding in families can be not as good as it should be. And I will speak, I will mea culpa on behalf of the male population, that men are not always very good at understanding this in their wives and partners. And I think we come across some pretty antediluvian behaviors, if you like, in terms of understanding and sympathy. And I think there's a great piece that Tilly Hale, who was a patient I looked after, wrote and said that one of the problems of this is that nobody will ever recognize that there's a problem because you look well, and they'll tell you that, and so in a way that's part of what we all have to do too. And I think the information from the foundation, other places, give that to family members to understand it, get them to come on these calls,
get them to talk to me. I'll have to talk to anyone, and everybody's PBC is different. This brings me to the next question. I hear this a lot, David. This is a very good question. I seem to feel unwell a lot and often have the feeling of having a virus coursing through my body. And this is how I describe my fatigue. Is this a classic syndrome? Now, I would say to this person, before I hand you over to the real expert, is that I want this person, whoever you are, I want you to look closely at your diet, what exercise you do. And I don't like that, but I don't mean go for a gym. I mean out for a walk, and even in the rain, wrapping up, making sure that you're keeping your body moving and not giving in, lying down, going to bed. And we want to really process foods, sugar, keep as little in your diet as possible. I know sometimes we're so tired to cook, but we can make a big pan of soup. People of our age, that's what we do. We freeze it. My boys still come around and read the soup out the freezer. But make life easy for yourself with good, healthy food and water. But the sugary drinks, David alluded to, cut them out. So that's my nag on that one. But whoever this person is, I'm more than happy to speak to you. So David.
So flu-like illness. Okay. It's very. So the reason you feel fluey is not because of the virus. It is because of the chemicals your body produces in response to the virus. Okay. So your body naturally produces things like interferons and cytokines and a variety of different things, and they are used by the body to fight the infection. All right. And they make you feel tired and washed out. We know this because people will be familiar with hepatitis C as another liver disease. In the early days of hepatitis C, we used to give interferon as a drug. Okay, injections of interferon, and people would feel like they had constant flu for the whole duration of that treatment. They stopped taking it, it went away. It wasn't the hep C, it was the interferon mimicking what the body normally does. So when people have got a flu-like illness, it just means there is inflammation around. There is something which is activating the immune system. All right. Why is it that these things make you feel tired? Well, that's a protective response, isn't it? So actually, if you've got an infection, it's good for your body to rest, not put pressure on it. So we've evolved to do that. So that these chemicals make you want to rest, because resting is a good part of fighting the infection. So it is part and parcel of any disease with inflammation. we do think in PBC, a lot of people will say, oh, it's just inflammation for PBC fatigue. We think it's more than that. We don't think it's as simple as that. We think there's something about the bile acids, the bile flow specifically. So it's not just inflammation, but there will be an inflammation there as part of it. How can you fight the inflammation? I'm going to echo what Collette said. Plenty of water, keep well hydrated, wash those chemicals out and through, good quality. A lot of fatty food, for example, is pro-inflammatory. It makes one of the reasons why people with fatty liver disease feel very tired is because the fat is inflammatory. So low carbohydrate, low fat diet, plenty of water, and don't underestimate the power of paracetamol. I mean, a lot of people with liver disease shy away from it because it causes liver problems. It only causes liver problems in overdose, and it's actually very good for damping down inflammation and allowing people to sleep if you're feeling very kind of fluey at night. Just be careful. Our rule of thumb for people with liver disease is to take half the standard dose. So not 2 tablets 4 times a day, 1 tablet 4 times a day, and you'll be absolutely fine. So you do not need to avoid paracetamol. Just watch out for the trap. We had a little run of this few number of years ago where there was a little flurry of what we call inadvertent paracetamol overdoses, where people have not tried to harm themselves, but they've just taken too much paracetamol. And it was because there was a new kind of night nursey, kind of day nursey type of thing that was on the market, where it was quite hidden that it had paracetamol. So people were in good faith going and getting some paracetamol and also getting one of these compound preparations, and ended up taking too much paracetamol.
No, that's absolutely.
But don't worry for ordinary things. Just keep hydrated. The other thing is that there's some reasonable evidence that exercise, if you are very inflammatory, so you're very kind of viral, let's put inverted commas around it, that if you are very viral, probably exercise makes it a little bit worse. So just watch the exercise if you're feeling particularly
choose carefully. Absolutely. Somebody else has quite a long paragraph here, and basically they were diagnosed without any symptoms. An interesting comment. When he's eating out, she feels more tired, and you're thinking, just what's in the food where you're eating out? A lot of it is processed. And they just want to do what their friends do. Well, just do what your friends do. Do as much as you feel like doing. Just because you feel tired, that doesn't mean to say you have to rest. You just balance it out yourself, keep to a good diet, as we've been saying.
So, Collette, here's a question. Do you know the scientific basis of snoozing in front of the TV after a good Sunday lunch?
No, I love a good Sunday lunch.
So there's a chemical called interleukin-6, which is one of these inflammatory cytokines. So it's a big feature in fatty liver disease. It's also elevated in PBC, but it is released by your stomach in response to a big meal. Okay. And presumably to stop you doing things and to allow you to digest the food. So there is an actual scientific basis for why you go to sleep in front of the football on a Sunday afternoon. It's to do with that, and it just shows that a lot of these chemicals, you think they're part of the inflammation, but they actually have other uses. So vitamin D, everyone's very familiar with vitamin D about bones, and we've talked about it with osteopenia and things, but it actually also helps regulate the immune response as well. So the body has these quite complicated ways of controlling all of this. And I think that there's a really useful bit of information or way of thinking about it is listen to your body, right? Listen to what your body is saying, and if it's saying rest. If it's saying I feel a bit better today, use that and do more. If you do more on a day you're feeling better, you will not hurt yourself, you will get just a little bit fitter. But don't get into a spiral of doing less and less and less and less, because you'll feel worse and worse and worse.
And do remember, other things can make you feel very tired. I had a call, it was last Sunday, and this lady, she says, I do my best and I walk my dog, da, da, da. She says, I'm really, really tired. She said, all day I just kept lying on the couch and sleeping. She phoned me back the following day. She says, I hadn't realised I was actually constipated. And she said, she took laxatives and she was in and out the loo for 2-4 hours. And she was fine, right? But again, enough water and that might not happen.
Can I just, without getting too philosophical, one of the things I talk about in the clinic, the symptom, the fatigue clinic, is the snake, all right? So if you look at, if you think of complete health being a straight line with everything working normally, in reality, in life, it looks a bit like a snake, and that's up and that's down and that's up and that's down, right? And each of those things may individually be quite a small thing, but these are the ways in which your body is not working perfectly. Now, we can look for the magic cure, the thing that takes everything away, but in life, it's usually more complicated than that. And so, in fact, what we do is we look for what's causing that to go up and that to go down and that to go up and that to go down. And if you correct all of those, in our experience, people's symptoms get much better. And that is precisely what Colette's just been saying, is that constipation may in its own right not be a huge thing, but it is contributing to this. And it is a way in which the body is not functioning the way you would like it to. And if it's not normal, correct it, because if you correct everything, it will by definition then be normal again, right? So it is something we talk about all the time. You could call it incremental gains, about looking for and correcting everything you can. And we've practiced this and looked at it a number of years ago and showed if you do this, then actually the fatigue will improve. Okay.
Yeah. It does. That's correct. So this one here is a bit of a worry. My liver biopsy was shown to be compatible with PBC. This is now a matter of eliminating other conditions. Is PBC easily identified? And then they go on to say, I have elevated bloods, no antibodies. My consultant's team not 100% sure from my biopsy. Is this second opinion here, David?
I think so. I think so. Biopsies are a double-edged sword in PBC, and so the vast majority of people don't need a biopsy. Okay, and in the days when they had them, that was unnecessary. However, there are some people who are really benefited by it, where there is a diagnostic question, right? So it's sometimes it's very straightforward. It's A plus B equals C, and sometimes it's more complicated with the pattern of tests and things. There is also the possibility that people can have kind of things like overlap syndrome, and there is a possibility there can be more than one condition. So in America, they see a lot of fatty liver disease together with PBC. We don't see that so much in the UK. So sometimes it can be difficult to piece it all together, or you've got contradictory information, in which case sometimes a biopsy is important. One of the issues with not doing vast numbers of biopsies these days is people become less equipped to look at them. And remember, there are kind of
running in my head, which is why I suggested a second.
Yeah. So there are two kind of people involved in kind of interpreting a biopsy. One is the pathologist who looks at it down the microscope, and the other is the clinician who will contextualize it. That's really important. So we have a meeting where we look at all the biopsies that have been done for all the diseases, and the pathologist. So we tell the story, and then the pathologists say what they see in the context of knowing the story. And I think that's where it's very important. Some biopsy patterns, sometimes in PBC, you can get a biopsy that is not diagnostic. The disease is patchy, so you sometimes can have an area that doesn't have the disease. Sometimes you can have more than one process in it all. Assuming they've done a biopsy for a reason, which they will have done, then you need to follow that through to its logical conclusion. Because if the question is, I don't know what to do in terms of treatment, and that's left after the biopsy, it needs to be looked at. All PBC, and I not make an assumption that it's somebody from the UK, but obviously may well not be. In the UK, there's a network to do with second line therapy, is that there is a a network whereby every single square inch of England is covered by a network of centres about second line therapy. So it doesn't matter where you are. There are 22 centres that will look at therapy, and those all feed into, the three big centres. And so there is always a route to get people to look at a biopsy, and the pathologists frequently send biopsies to other centres to get an opinion. You don't necessarily need to go; the biopsy can go for you. And so there is a route to do all of that. So that's well established. Outside the UK, it's a little bit less well structured. Sometimes it can still be a little bit grey, and then it comes down to a judgment call. And I think in that situation, you're kind of heading to second opinion for sure, because often I can. To be honest, I spend my life talking to people with PBC and looking at biopsies and all of that. And 9 times out of 10, if somebody's really puzzled about something, if we have a look at it, it's actually pretty straightforward. It's just not something they've encountered before. So there is no need to have an ongoing mystery about these things. If it was important enough to do a biopsy, it's important enough to have somebody.
Absolutely. And I would urge that person to get back in touch again. If feel free to do that. David, we're kind of running out of time. You got a quick couple we can do here. So somebody's asking, in terms of versos, the lowest dose, could raising it increase your chance of normalization? You take your verso according to your weight. This is the PBC Foundation weight chart. It's an imperial, it's a metric. So
here's what I've
find that online. I've been doing this for so long, David. So it's on weight. There you are. That's your medical question. These are my
there is no need to go beyond 15 milligrams per kilogram. You do not get additional benefit. If you are below the 13 milligrams per kilogram, it is worth going up to the right dose. But the likelihood of it getting a benefit, am I a non-responder to urso because I'm on too low a dose? If it's a tiny dose, possibly. If it's almost the right dose, it's unlikely to be that, but it is worth doing it. And the rules for a lot of these drugs require you to be on the right dose. So it's important.
And bear in mind that our weight does fluctuate, and in COVID, quite a lot of people were putting on weight and not realizing that to look at, that's why we produced the chart. Correct. Right, we've got 2 wee ones. One of them is a bit complicated, but we'll do our very best. So how is PBC related to random general inflammation infection? I think we've actually covered most of that, David, would you say? Yes, I think we've done that very well, actually. You always mention inflammation, David, always. So the last one, and it's complicated with words I might not even be able to pronounce, but I'll give it to you anyway. Please comment on whether apolipoproteins should be tested, and if elevated, LDL treated with same target and considered pathogenic versus elevation, a disease marker that is not pathogenic. I have no idea what that means.
So lipoproteins are the way the body transports cholesterol around the body, and they're important for understanding cardiac risk, or atherosclerosis, cardiac vessel risk. And they are a source of endless mystery and confusion to people managing PBC, because the total cholesterol number is usually elevated in PBC, but it is also usually not the high risk cholesterol, which is low density lipoprotein and very low density lipoprotein. So cholesterol, the total number is usually elevated, but it is far less common for it to be a worrying elevation. That said, having PBC does not protect you from having a worrying elevation, and obviously it therefore needs to be thought about. So the message for PBC is don't rely on the headline number, do a split, which we have to ask for specially to measure the HDL, which is the good cholesterol, which is the one that's elevated in PBC, and then the kind of quotes bad cholesterol, which is the non-HDL cholesterol. And so if that's elevated and you've got other risk factors, then that's worth treating. But actually most people that elevation in cholesterol, it's not that. Having said that, in the UK it seems to be almost impossible to get GPs to not give people statins. They want to pump them into buildings in the air, I think. So it doesn't matter what we say, the GPs just start statins. But just remember, the cardiac risk in PBC is actually pretty low. There's no excess risk, and because the majority of people are women who are at lower risk anyway, the overall risk is quite low. But that does not protect you if you've got a family history of heart disease, and it does not protect you if you're a smoker. And actually, we do know smoking is a little bit more common in PBC, or certainly used to be, than in the broader population that, you know, Collette knows from research the foundation did. So just watch out for smoking. It is kind of never a good idea.
Yeah, absolutely. David, we've done! Yay! Go to the top of the class. So somebody just come in, another eureka moment. Thanks for explaining. I always feel like that's lovely. I'll always learn something from these. So do I.
And I think this
something I bet you didn't
this,
know.
this thing about inflammation, the chemicals that your body produces in response to a virus being why you feel virusy, is actually quite important. I can tell you, people with no immune system, okay, who get flu virus simply die without ever feeling unwell, right?
Wow.
Because the death is caused by the virus, but the unwell is caused by the response, and they can't respond to the virus. That does not apply to anybody on this call. Please do not interpret that the wrong way.
No.
But it is really important.
I'll tell you something that you didn't know. I only found out a couple of years ago from my retired hepatologist. He's nearly 90 now. I apparently am the first person in PBC to be diagnosed in this country without having had a biopsy.
Is that right? Mm-hmm. Just on antibody? Yeah.
Mm-hmm.
Well, that's normal now. And the reason is that the antibody is in fact more accurate than a biopsy, because the biopsy can be patchy. So leave aside
that's right. Yeah, exactly.
Leave aside all the other issues of not wanting a biopsy. I mean, leave that aside.
Yeah.
It's a patchy disease. The people in Birmingham, James Neuberger showed this actually, you know, that you could do a liver biopsy, you know, in somebody's liver that had been taken out of transplant because they needed a new liver for PBC, and there'll be normal areas in the liver. Whereas the antibody is a pretty marker. The problem is about 4% of PBC patients on biopsy don't have the antibody, and that might be the case with the biopsy that we were.
But absolutely, I was thinking that too. But David, thank you so much. We've got another comment. The dream team. Thank you, Collette, Prof Jones. There we go. Maybe I'll get a job here then.
Robert who?
So listen, everybody, I still continue to run the helplines. If you need to speak to me, I will do that. David, thank you so much.
And just on that note, I mean, I'm not just saying this, the helpline team are brilliant, but there is no such two things. One is there is no such thing as a stupid question. Okay. I have never ever in all the years I've been doing these Q&A had a stupid question, right? They're all interesting questions and we can unpack them. And the other is that often anxieties and worries that you have are really easily, you know, dealt with. And I think don't sit and worry about it and kind of, you know, share it, because
no question is daft. It's real,
almost
earnest,
particularly around the symptoms. Everybody comes along and goes, I'm sure I'm the only one, but and they just then tell the story, which is the one you hear from absolutely everybody. And that sharing of it is actually really helpful in my experience.
It's huge. David, thank you. I will hopefully see you soon. Thank you, everybody. Jacqueline in the background. Thank you. Bye, everybody. Bye-bye.